Chapter 12, the primary assessment. So Chapter 11 dealt with scene size up, and it discussed a lot with things that we should be considering or identifying from the minute that the tones drop all the way up through the transfer of patient care at the hospital. We need to be identifying things like scene safety concerns that may be evident or even subtle. We need to look for clues as to what could have happened and the potential injuries that may exist based on mechanism of injury or nature of illness. And we need to be sure that we're treating all the patients and that we have the necessary resources to do so. Now, the primary assessment here is an extension of that. Once we complete the scene size up, and we have to again remember that the scene size up is continuous, right? It's repetitive throughout the entire patient interaction, as is the primary assessment here. We are continuously evaluating the scene, looking for new clues, and we are continuously evaluating the patient throughout the primary assessment and doing that over and over and over again. And what that allows us to do is identify changes in the patient's mental status, their airway management, respiratory control, or even circulation quality. So keep in mind that while we begin to do different practice scenarios in class, and while we are trying to really develop a rhythm in patient assessment, the scene size up, the primary assessment, these are things that we should have memorized. We need to follow them step by step at the beginning. And then over time, as we get really good with it, as we develop a level of proficiency, that's when you'll start to see some of these things kind of flow together. Maybe we're multitasking, maybe we're completing multiple components at one time. But generally speaking, they need to be done in order so that we don't miss any critical components. So looking at the primary assessment, there's a few different priorities that we are trying to accomplish here. The biggest of which obviously is the focus on life threats. And those life threats are something that would dictate us actually stopping our assessment and working to adjust them. So throughout our patient assessment, we're going to identify lots of potential things that could be wrong, many contributing or underlying factors to the patient's condition. But we never stop our assessment until or unless we identify something that is an immediate life threat to the patient or to ourselves. And as you can imagine, the things that are going to be the most prevalent when it comes to life threats are going to be issues with airway, breathing, or circulation. And going back to our perfusion discussions in the past, you know that those are the three requirements necessary in order for our perfusion quality to be sustainable and to maintain a good quality of life. So let's look at some of the basic things here. We know that the primary assessment here includes ABC assessment, airway, breathing, circulation. Now, there will be instances where we need to do a CAB assessment, where circulation, airway, and breathing is done first. And if you think about it, that's exactly what the American Heart Association teaches you to do in CPR. If you walk up to a patient, you first identify any scene hazards, make sure that the scene is safe. From there, then, if they're unresponsive, they're not talking or responding to anything that you do, you check a pulse. And that pulse check is part of the circulation component. And assuming that they don't have a pulse, you immediately begin compressions. And that is, you've identified a life threat, and in that case, the circulation is not sufficient to sustain life, so we're working on compressions to try to artificially do that from the outside. After 30 compressions, we assess the airway. We reposition the airway to make sure that it's open. We identify the potential for foreign body obstruction. And then from there, we place a pocket mask or a BVM over the patient's face, and we begin delivering ventilations. So that is the airway and the breathing component there. So again, the only time that we assess or treat in the order of CAB is in the instances of a patient being unresponsive or generally altered. Otherwise, we're going to assess and treat everything in ABC priority. So what that means is on your exams, if you come across a question where multiple answers are correct, you're going to want to treat them in chronological order based on order of priority. And in all circumstances, you're going to treat them in ABC order, with the exception, of course, of being the unresponsive patient in cardiac arrest. Now, along with that, when we get into trauma, we'll start talking a lot about hemorrhage control and how we need to be able to control bleeding in conjunction with airway and breathing. So there's going to be a little bit of a gray area there, a little bit of an adaptation. But for right now, again, I want you guys to remember we treat in the order of ABC unless they're unresponsive and we have to do CPR in which case it's a CAB assessment. So decision making in the primary assessment. We want to look at things that could be preventing the patient from perfusing, which obviously could be something as simple as fluid in the lungs or lack of adequate oxygen. We know that substantial hemorrhage, if we don't have enough blood in the body, not only would that cause hypovolemia, but we also deplete the quantity of red blood cells that are available to transport oxygen. So no matter how good I do at managing the patient's airway and delivering oxygen, if I don't have enough blood and red blood cells within the patient's body, none of those efforts are going to be useful. So I have to be able to identify, is the bleed truly a life-threatening bleed? And if so, is it a higher priority to stop that bleed than it would be to manage the airway? At the end of the day, I think everybody would agree that managing the airway, ensuring that there's an adequate supply of oxygen, and ensuring that there's good circulation, they're all equally important. And we have to be able to really discriminate between the patient's conditions and determine what is the highest priority right now. What do I need to do first in order to give this patient the best chances of survival? And I can't tell you that it's always going to be one thing or another. I can tell you that we're going to have to evaluate, assess our patients individually, and make determinations on a case-by-case basis. So here it's just a reminder that if immediate interventions such as bleeding control or CPR are not required, shift into an important but less urgent mode in which you will administer oxygen appropriate for the patient's condition and evaluate for shock. So we're looking at what are some things that we can do to help our patient. As we assess the ABCs, as we complete our primary assessment, we may not identify any immediate life threats, but we may identify some pretty urgent issues that, if not corrected, could lead down the road to a life threat. So again, we're going to evaluate our patient and make determinations, come up with a treatment plan, and implement it. So the basic steps of the primary assessment are listed here. We're first of all going to form our general impression. And the general impression is really our gut instinct. As we pull up on scene, as we first see our patient, as we first see the incident, what is it that goes through our mind? And sometimes it's simply, oh crap. We pull up on scene, we see something, it's bad. And that's the first thing out of our mouth. And that gut instinct should really be a major contributing factor to the management of that call. If we pull up on scene and we're like, oh my goodness, this is a terrible car accident, it's an incredible amount of damage, or we look at a patient and they're pale and they're diaphoretic and they're altered, we can just tell that they're really, really sick. These things should say, hey, this is a critical patient. I need to really manage my scene time here. I need to expedite things. We need to call for additional resources or manpower to make sure that we can effectively manage this patient. The general impression, that gut instinct, is the driving force behind the remainder of your call, or how you manage it, rather. From there, we want to look at mental status. And as we walk up to a patient, we should be able to identify whether or not they're awake or asleep. And when I say asleep, I mean that, because yes, they could simply be unconscious, but there's been plenty of instances where we respond for an unconscious patient, and all it is that they were sleeping, and we wake them up, and everything's fine, and we go home. So looking at the patient as we walk up, what's our general impression? Are they awake or are they not? And from there, we can determine if they are awake, are they confused or are they oriented? If they're not awake, are they alert to, or do they respond rather to verbal or painful stimulus, or are they simply unresponsive? And we'll get into that a little bit more in just a second as far as how we differentiate between that. Assessing the airway. We should be listening for airway sounds. Do we hear snoring? Do we hear gurgling? Are there audible wheezes? What about breathing? Are they working hard to breathe? Are they tripoding? Or do they seem to be moving air effectively? Their circulation. We can identify simply by looking at skin parameters whether or not they appear to be circulating effectively. If they're pale or if they're cyanotic, that tells me that we have a big issue. But if their skin parameters are within normal limits, maybe assessing circulation includes checking the radial pulse. Do they have a strong pulse, or is it weak? Is it regular? Is it irregular? All those components play into the circulation assessment. And once we've completed our primary assessment, we're going to determine what is our patient's priority here. Is this a time-sensitive critical patient where I need to load and go? Or is this a patient that would benefit more from on-scene interventions? And I'll tell you that beyond just simply determining load and go or stay and play priority on scene, now we also, within our system, have to determine what hospitals to go to. We know that Woodstock Hospital is nothing, is a comprehensive ED, but it has very limited resources available to it. So generally speaking, any trauma patients or any patients that are really sick need to go to either Huntley or McHenry. But at the same time, if a patient is critically unstable, if we're concerned about whether or not that patient's going to have a pulse or remain alive in the next few minutes, we're going to go to the closest hospital, regardless of capability. Because at the end of the day, getting to any ED with a physician and the resources and tools that they have available to them is going to be better than the back of the ambulance. So time-sensitive critical patients that are unstable and unable to be managed effectively by the EMS crew would go to the closest hospital. Patients who are very serious and sometimes critical, but can be effectively managed for the duration of the transport, should be taken to one of the outlying hospitals, such as Huntley or McHenry. OB patients, patients who are pregnant and experiencing some type of issue with the pregnancy, going to Woodstock is completely ineffective because they have no OB resources there whatsoever. So we need to be transporting those patients out again to either Huntley or McHenry. And the same thing applies with cardiac patients that are potentially suffering an MI. They need to go to those outlying facilities. So these are all things that we group into our patient priority, transport decisions, and everything else. So getting a little bit more into the general impression here. I'll share a couple stories here. One of which I remember we were dispatched for a gentleman who was hit by a car. And as we arrived on scene, excuse me, it was the middle of the night. The patient's laying in the middle of the roadway, not breathing, and just lying in a giant puddle of blood. Now, based on that, this is what we call a windshield survey, right? I was able to observe those findings sitting in the front seat of the ambulance looking through the windshield. I didn't get out. I didn't touch my patient, talk to my patient, or anything else. My general impression from that front seat, from that windshield survey, was that this patient was going to be in really bad shape and that we were going to be ineffective at managing the patient's condition, right? Simply by observing the quantity of blood that was on the ground, I knew that there was nothing that we could do in that ambulance that was going to fix these issues and allow for that patient to continue to perfuse effectively. So the decision was made immediately, again, prior to even touching or talking to the patient, that we were going to load and go. And that's exactly what we did. We got out. I told my partner, grab a backboard. The engine company was right behind us. We went down. I did the quickest trauma assessment you can ever imagine. We took some very rudimentary C-spine control, rolled the patient onto a backboard, put him on the cot, jumped in the back, and I'll tell you, when you watch shows on TV, they slam the ambulance door, they pat on the door a couple times, off the ambulance goes. Well, I can tell you that's entirely unrealistic. It never happens that way, except for this call. I had a driver up front ready to go. The back door of that ambulance closed, and off we went. The remainder of our assessment, airway management, oxygen delivery, IV access, hemorrhage control, everything was done in the back of that ambulance, and the ambulance was moving toward the hospital. In that same situation there, I contacted the hospital and I said, hey, listen, this is what we have. We're incoming with a patient. I gave him a description of what was going on. What I wasn't doing, though, was transporting to that hospital. We had called for a helicopter, and because the patient was critically unstable, and I wasn't convinced that they would remain awake, or I shouldn't say awake, I wasn't convinced that they would remain alive. We called that helicopter. We told the helicopter to meet us at the hospital landing pad. And in the meantime, I called the hospital and I said, hey, we're going to be parked right outside the ED. If this patient tanks on us, if they go into cardiac arrest, or if their blood pressure drops anymore, then we're going to come on inside. And I wanted to give the hospital an opportunity to be prepped for that. They needed to have blood products ready to go. They needed to have all of their staff downstairs and ready to roll. And fortunately, the helicopter got there in enough time. We were able to transfer care and get that patient moved out to a level 1 trauma center, which is what they needed. But again, in the event that something would have happened where they went downhill quickly, where they destabilized, we would have had the opportunity to simply drive about 50 yards, go into the hospital, and transfer care to, albeit a higher level of care. So the look test, feeling from environmental observations as well as the first look at the patient, and that's that gut instinct that I told you about. Sometimes it's not just looking at the patient either, it's also looking at the surroundings. If we go into a home for somebody who is, let's say we're dispatched for a child who fell and has a head injury. As we walk into the home, clues about the home could indicate the quality of life that the child has, the type of care that may be rendered, the child's behavior, siblings' behavior. All those things can all play into our general impression as to how we think things played out or what may have happened. So looking at this here, what is your general impression of this kid? And take a second and really look at beyond just the kid, look at the scene clues that are around. And as we see this here, we see, first of all, this is a young child, probably, I'm going to guess, maybe 5 years old, give or take, right? She's on roller skates. It looks like she's got a bloody rag on her knee here. She's got an abrasion on the forehead. Generally, she looks sad. But aside from all those things, she's sitting up on her own. Her eyes are open. She's awake. It doesn't look like she's crying. Her skin color looks good here. So these are all things that say, yes, okay, this kid probably fell, roller skating, has some trauma, but I don't see any uncontrolled hemorrhage. She appears to be awake. There's nothing about this that just stands out as being alarming to me. So I would classify this child, based on my general impression, as a low acuity or a relatively stable, not a super high priority type patient. Now, this is a very, very different situation. Taking a look at this here, I see an adult patient who is unconscious. Not only are they unconscious, but who typically lays in that position on purpose, right? If you were to lay down on the ground, you're going to lay down in a position of comfort. I've never seen anybody lay that way that is comfortable. Simply look at the positioning of the neck here and with the head laying on the ground. There's no way that that's comfortable. So that tells me that not only is my patient unconscious, but that they were unconscious when they went to the ground there. They didn't lower themselves down. They didn't put themselves into that position. So now I have to assume that the patient potentially fell. Okay. Looking even deeper, I see it looks like some bruising around the chest and the neck here. Is this going to be a battery patient, right? Was she assaulted somehow? If so, now I'm also considering that, her clothes and her body, this is subject to being a crime scene. So I want to be sure that I focus on patient care, deal with any life-threatening issues, but I also want to be very, very observant of everything I see. A detailed, accurate description of every piece of trauma, everything within the scene that seems out of place, the patient's positioning, all that will play into potential prosecution of the offender down the road. I don't like the color of her skin here. Aside from the bruising and everything else, she looks generally pale to me. I have concerns about the potential for internal bleeding in this situation. We would definitely want to take C-spine precautions, immobilize this patient. I would want to remove clothing from the patient so that I could identify the presence of bruising to the abdomen or the flank, other areas that would be subject to internal bruising or internal bleeding and hemorrhage. So again, these are all things that I look at this patient, all of that runs through my mind in the first few seconds, and my gut instinct, my general impression here is, oh crap, this patient's in really bad shape. This is going to be time sensitive, and we really need to move quickly. When I consider additional resources that may be needed here, I'm thinking I'm going to need the police for the potential crime. And because the patient's unconscious, I'm going to need at least 1 or 2 additional people in the back of the ambulance with me during transport. So I'm going to ask for additional manpower. Now this is another good one. Looking at this here, we have what appears to be a teenager with some various traumas. I see what appears to be a laceration on the right forearm. He's got some abrasions and lacerations on the head there. Looks like some bleeding maybe around that right eyebrow. this kid hasn't been involved in trauma. Now, I don't know anything about this, right? This is all I know. I'm going to jump to some conclusions. I'm going to stereotype a little bit, and all of that is okay. What I want to reinforce here is that the use of stereotypes, the use of assumptions is perfectly acceptable in EMS, so long as it doesn't cause tunnel vision, it doesn't put blinders on you, or you don't allow any biases to dictate your level of care or treatment. So while I can use these assumptions and these stereotypes to kind of give my best guess as to what may have happened, I cannot allow those things to impact the overall quality of care that is rendered. Okay? Everybody is deserving of the same level of care. Everybody is deserving of the same level of compassion. So again, looking at this, I see a teenager. When I think teenager, I think male. I think kids that are doing daring things, maybe on skateboards. I'm looking at the way he's dressed, long hair, the shorts and stuff like that. These are things that are consistent with what I vision, somebody out maybe doing BMX bike or skateboarding, longboarding, those types of things. So I'm thinking that, okay, maybe this kid was on a skateboard, he fell, took a spill. He's sitting up, he's awake. It appears that he's probably breathing. He's got an adequate airway. Skin parameters look okay. I think that these injuries are going to be more superficial than anything else. But I also know that I should right away ask about things like head, neck, and back pain. I should certainly assess the entire torso and lower extremities for the presence of other injuries that may be hidden, and maybe do a neuro assessment, look at his pupils and that type of stuff based on the potential for a head injury, concussion. So lots of things kind of going through my head here. What's my general impression? That this is a kid that probably fell and appears to be awake, maybe a lower priority patient, unless some findings dictate otherwise. Take a look at this one. Now this is a very, very interesting picture. First of all, take a look at the scene. Look beyond the patient. Where's the patient lying, right? The patient's lying down on a bench. Looks like the bench of a boat. I see water in the background. These cushions are consistent with the type that we would find on a boat. So I'm thinking, all right, what's going on? He looks dry, so he probably wasn't in the water, but he's out on a boat nonetheless. Now think about, what do you guys do when you're on a boat? I see this guy here that is appears to be unconscious, right? But look at this. He's got his phone in his hand. He laid his head down on his arm here. This is a position of comfort. So while he may be unconscious, he put himself into that position, right? That isn't, excuse me, that isn't a fall. Nobody threw him up there on the bench. He put himself into that position. As I look a little bit deeper, I see that he's got a laceration with some bleeding on the forehead there. So, okay, here's my general impression. I've got a male patient, probably upper 20s, lower 30s, out on a boat, maybe some alcohol consumption. Appears that he hit his head on something, maybe laid himself down, not feeling too well. I'm concerned about the presence of a concussion. I'm concerned about the presence of elevated alcohol that is going to inhibit clotting properties. These are all things that are playing into it. I'm also concerned about my ability to move this patient effectively. So if he's under the influence of alcohol and or just simply unconscious, he's a poor historian, right? He can't tell me whether or not he has head, neck, or back pain. I can't do a neuro assessment on this patient, so I need to take some additional precautions, and I need to immobilize, put that C-collar on, put the patient on a backboard, and just really, again, do a full comprehensive head-to-toe assessment, trying to identify things on my own. So this slide just identifies some of the things we've already talked about as far as patient conditions that would clue us into the fact that they're in pretty poor shape. Few additional examples, tripoding position as we walk up to a patient should be one of the first clues that they're in severe respiratory distress. Probably don't need to do a whole lot before I get the oxygen out, get them on that high flow oxygen, start treating that respiratory issue. Don't take the time to get a full set of vitals and get a medical history before you administer oxygen. We walked up, they're having difficulty breathing, assuming that their airway's open. The next thing we're going to do is administer that high flow oxygen, treating in that ABC priority. That Levine sign there, that's the patient, as somebody who has chest pain, they kind of clutch their chest a little bit. That's what that is. We should look at those things. If I were to walk up and punch somebody in the stomach, their natural reaction would be to keel over and they kind of hug their stomach where I punched them. That's a natural response called guarding. We look for things like that. If somebody's guarding themselves, if they're in a tripod, they're demonstrating the Levine sign, just their body positioning alone can tell us a lot about what's going on with them and what their chief complaint is most likely going to be. Conveniently, that leads into chief complaint. So as we walk up to our patient, assuming that they're conscious and able to talk and respond appropriately, we need to ask them what's wrong. Now, that simple open-ended question can lead into quite the long narrative. So sometimes we need to refocus our patients and be more specific. Simply than just saying what's wrong, we may ask them, why is it that you called 911? What is it that's gotten worse that just caused you to need to make that phone call? How long has this been going on? Getting some more information. Patients may have multiple complaints, and it may be difficult to decipher between the chief complaint and secondary complaints. A patient who's having a heart attack may complain equally that their chest hurts and that they can't breathe. And if at the end of the day we can't identify one single complaint as being the biggest concern, that's okay. We can have dual chief complaints, but generally we want to try to identify what's the biggest issue right now. Let's focus on that a little bit, and we can identify all the other complaints as being secondary complaints. So using the chief complaint and our general impression together, we're going to do that full assessment. And that assessment is going to be, again, from a distance before we ever go hands-on. Looking at things like the patient's age, gender, their overall positioning, that tells me a lot. How certain teenagers respond between males and females. I know that there's a difference there. Sometimes that dictates just my communication style, not to mention some of the underlying factors. If I have a 18-year-old female with chest pain compared to a 57-year-old male with chest pain, I know that 57-year-old male is predisposed to additional cardiac issues simply based on age and gender. And I know that 18-year-old female with chest pain, there's a higher likelihood that it's going to be something other than cardiac in nature. Doesn't mean that I'm going to rule out cardiac, but I am going to use those patient demographics as discriminators so that I can kind of focus on the higher likelihood things first. And if I'm unsuccessful identifying what the underlying issue is, then I'll still consider all of those less frequent or less common issues as well. I'm going to listen to not only what the patient says to me, but how they're talking, moaning, snoring, those airway sounds like gurgling. I'm going to use smell. Something like urine or bowel content. If I walk up to a patient that's unconscious or unresponsive and I smell that they've been incontinent, that's a big clue, right? Incontinence indicates some severe neurologic issues that have gone on there. And I'm going to use that to identify the potential of death, right? I need to quickly check a pulse and make sure that they have one, because once patients die, once their brain activity stops communicating with the remainder of the body, then what we see is incontinence of bowel and urine, both in most cases. I could also look at things like, do I smell fumes in the air? That would indicate that the patient's been overwhelmed by something. Is there a hazardous materials issue? Cigarette smoke and identifying the presence of a bunch of cigarette butts could lead me to the fact, okay, that this patient's a heavy smoker. Maybe there's a respiratory component to this. Just a lot of stuff going on. We can really use all of our senses with the exception of taste. I can't think of a single example where you should ever taste anything having to do with patient care. All right, mental status. Super important concept here. So we have the AVPU scale, right? AVPU is a mnemonic to help you kind of remember alert, verbal, painful, and unresponsive. Now, I've put together a little chart that kind of, I believe it better illustrates exactly what AVPU is and how to use it. And here it is. So the A in AVPU stands for alert, and any patient that is conscious, we would determine them to be alert. From there, we want to determine whether or not they're oriented. So you hear the term or the phrase alert and oriented all the time, and this is where it comes into play. They're awake, they're talking to us, so we know that they're alert. Are they oriented to person, place, time, and events? And there's some sample questions there that would allow you to identify whether or not they are. Can you tell me your name? Who are you? What's your date of birth? All of those things will play into that. Do you know where you are? Think about your patient demographic too when you're asking these questions. Is this a 90-year-old patient in a nursing home who is typically confused? Or is this somebody who should be able to identify who they are, where they are, what day of the week it is, etc.? When I say, can you tell me what day it is? That 90-year-old patient in the nursing home, that's probably not the patient that's going to know. Frankly, they don't have a reason to care. They may know that it is Salisbury Steak Day. They may know what year it is. We could even say, can you tell me what season it is? Just try to determine whether or not they are able to answer any of the questions related to person, place, time, and events. And if so, if they can answer 3 questions appropriately relating to those categories, I would say that they're alert and oriented times 3. If they answer all 4, they're A&O times 4. Or if they only answer 1 or 2, they'd be A&O times 1 or 2 respectively. Now, if they are unconscious, meaning that as you walk up to them, their eyes are closed and they're not actively awake or engaging you, if you are able to stimulate them somehow with a verbal command, so, hey, can you hear me? Are you okay? If they do something like open their eyes, if they moan, if they move a part of their body, if they do any of that stuff in response to that verbal command that you gave them, then they are unconscious but responsive to verbal. Now, if they simply open their eyes and wake up and start talking to you, right, then they're probably conscious and alert, and we just need to determine that level of orientation. But generally speaking, if they don't wake up, if they don't start responding under normal circumstances, we'd say they're unconscious but responsive to verbal. And the same thing would apply for painful. Again, we would identify or we would inflict some level of pain that is acceptable within EMS standards. And typically that's something like taking a pen and applying it to the nail beds. And these are things that we'll practice in class. Maybe you could press over the eyebrow. There's some humane ways to inflict a pain response without actually harming your patient. And if they're unconscious and you inflict that pain response and they again open their eyes, moan, move, groan, something like that, we would say that they are unconscious but responsive to pain. And then if we give verbal commands, if we try to inflict some pain and we don't get any response out of them whatsoever, that patient would be considered unresponsive. Now, these are the types of patients that as we walk up and we find them to be unresponsive, the next thing we should be doing is checking a pulse right away. And this whole AVPU assessment shouldn't take more than just a couple seconds to do. It goes pretty quickly. If they're unresponsive, we check that pulse. And obviously, if they have a pulse, we start looking into some underlying issues. If they don't have a pulse, we transition right away into CPR. So now we've determined our general impression. We've established the patient's mental status, and now we want to transition into assessment of the ABCs. And this slide just reiterates that the order of assessment is going to be dependent on the patient's condition. Typically it's ABC, but if they are unresponsive, we would again do that CAB assessment. So looking at this patient here again, we look at scene clues, we look at the patient's positioning, everything else. This patient here most likely fell. I would not anticipate them to lay back the way that they are, but you never know. Obviously, this scene here is staged, so I'm sure that the patient put themselves into that position, but probably under the instruction of how to lay down, how to look. I look at how their feet are flared out here. I looked at their eyes are closed and unconscious, arms are to the side. If this were a real scene, I would predict that this patient probably fell backward from a standing position. So yes, what caused them to fall? Is there an underlying medical condition? But now I also need to consider the potential for trauma as far as a head, neck, or back injury. If this patient were laying closer to the table or couch over here as they fell, did they hit their head on a table or couch? Could it have caused some type of a spinal issue? Could it have caused a concussion or other head injury? Just a lot of stuff that we need to be evaluating as we look at the overall scene. Assessing the patient's airway, we've talked extensively about monitoring airway and providing oxygen therapy. We want to make sure that airway is open and patent, and if not, we want to fix it immediately. As we walk up to the patient, if they are unconscious and unresponsive, we check a pulse, and assuming that they have a pulse, we want to identify airway and breathing issues. If we hear snoring or gurgling, we should take immediate steps to correct that, because that tells me that they're not moving air effectively. And I would do that using a head tilt chin lift if they're snoring, or a jaw thrust if I suspect trauma. And the other thing I would do then is if I hear gurgling, is I would right away go ahead and do some suctioning. If I hear stridor, I'm thinking, okay, do they have a swollen airway, or do they have a foreign body obstruction? I'd probably open up the mouth, I'd look in there, see if I see an obstruction, and if so, attempt to remove it. Breathing then. Beyond simply are they breathing, how are they breathing? What's their overall work of effort? What's the respiratory rate? Is their breathing pattern regular or irregular? And from there, we need to determine how much oxygen we need to give them. And I'm going to base that on things like their positioning, their skin parameters, the patient's complaints themselves. I want to look at SpO2, a whole bunch of things there that help me determine, what type of oxygen device to use, what volume of air to be flowing. All these things play into that overall treatment plan. And then circulation, looking at skin parameters, checking for a pulse, identifying the potential for shock, and everything else that would be related to that. Based on all these things, now I want to determine priority. So is this patient, again, somebody that would benefit from us staying on scene and performing some basic assessments, or is this a patient that needs to really be a load and go type patient? Take, for instance, a diabetic. Let's say we have a diabetic patient with a glucose of 61. They are mildly confused. I could, A, stay on scene, provide oral glucose, and make them a sandwich or get them a candy bar. Or I could, B, throw them in the back of the ambulance, transport them quickly, knowing that more than likely they're going to become awake, alert, and oriented within the next few minutes, assuming that we can get their blood sugar up. And obviously the preference there would be to treat the patient at home, provide that oral glucose, go check out the refrigerator, make them a sandwich or get them a candy bar, and allow the patient to self-correct. And as that happens, the patient's likely going to refuse transport, especially if they're a known diabetic. These types of things happen all the time. Conversely, if a patient is having crushing substernal chest pain that radiates to the left arm and neck, they're short of breath, they're pale, they're diaphoretic, this is a patient that, hey, there's nothing I'm going to do on scene to make this better. Let's get him in the ambulance right away and let's get moving. Obviously, patients who are in cardiac arrest, we work cardiac arrest right where we find them. We do not transport cardiac arrest patients in most circumstances. There are some exceptions, but generally speaking, if we find a patient in cardiac arrest, we leave them where they are, we start compressions right there, we use the AED right there, hopefully requesting ALS resources if you don't have them available, and we're going to work that arrest right where we find that patient. Again, there are always going to be exceptions. If I find a patient in cardiac arrest outside in sub-zero weather, obviously that environment is not conducive to working in arrest, so we're going to move them and put them into an ambulance. Many of times with young children, let's say that we have an infant in cardiac arrest. There's no reason to work a 6-month-old inside of a house when I can get outside to my ambulance within about 15 seconds and work the arrest in the back of that ambulance, and especially be on the way to the hospital while doing so. So our circumstances will determine whether or not we stay and play or load and go. And again, there's so many different variables there. It's a judgment call. We have to just understand the pros and the cons of making each of those decisions. So there are many times when it's not crystal clear what a patient's problem is. So there will be many possible diagnoses, and more serious than others. This happens. It's frustrating when we can't identify what's wrong with the patient. We don't know what to fix. Obviously, that's a load and go patient. Let's get them to the hospital where they can do some more diagnostic testing, blood work, and everything else, and see if we can't figure out what the underlying issue is. So this slide just reiterates some of the points we've been making as far as identifying our limitations and getting them to the hospital to transfer to a higher level of care. So this concludes Chapter 12. In summary, as we perform our patient assessments, every patient is going to be deserving of a independent, customized assessment that focuses really on what the underlying conditions are for that patient. Each treatment plan is going to be different. And what that means is that we can't simply rely on our protocol books or what our teacher instructs us in class on how to manage our patients. We have to develop this underlying understanding of all things having to do with patient care and assessment, and we're going to have to develop a customized treatment plan for each and every patient. It requires a lot of understanding, a lot of critical thinking on behalf of the EMS provider. So this is as we kind of dip our toes into the water of patient assessment here, expect things to get far more in depth, and we really start to kind of narrow down what are these underlying issues, how do I identify them as quickly as possible, and most importantly, how can I treat them? So thank you very much for your time, and we look forward to seeing you in Chapter 13.